after I see my message.
Testing 1 2. Test 1 2.
I saved some time for questions. I thought there was going to be, but so we may end a little early. That's fine.
Okay,
So we are up and rolling whenever you're ready.
okay. So just
Okay.
introduce yourself and get
All right.
started, and I'll be back in when you get through. I'm gonna go watch it, make sure nothing goes wrong on the live feed.
Thank you very much.
You're welcome.
Hello, good afternoon. Is the volume okay? Okay, perfect. I'm Martin Rodriguez. I'm a professor of medicine at the Division of Infectious Diseases at UAB. I'm the clinical director for, the director for clinical activities. And I was asked to give you a little bit of an update on COVID-19, obviously a topic that is very pertinent at this time. I'm going to go through different things, starting with a little bit of just information about the virus, and then focus more on the epidemiology, how the disease is transmitted, go over some clinical manifestations, diagnosis, testing, and then end with what do we have for treatment at this point. I understand there is not going to be opportunity for live questions because of the way this is being set up, but they have my email, and I believe you can send questions via email, and then those will be forwarded to me, and I'll be happy to try to answer those. So thank you for spending some time with me today. Okay, so this is the virus. This is the coronavirus 2, SARS coronavirus 2, that's the official name. SARS, you may remember in the early 2000s there was this outbreak of this viral infection that started in China actually, and then spread to other places of Southeast Asia and even reached the US and Canada and other places. That was called SARS. It was also a coronavirus. At that time, the name of this was SARS, and then there's another one that has been hanging out in the Middle East called MERS, Middle Eastern Respiratory Syndrome, and obviously more recently, since December, we have recognized this virus, SARS coronavirus 2. The name of the disease is COVID-19. The name of the virus is SARS coronavirus 2. So I may be just talking about coronavirus in general, but please be aware that there are many kinds of coronavirus. Actually, it's important to keep in mind, and that created a little bit of confusion early in the outbreak. Coronaviruses in general are actually a very very common cause of cold, the common cold. We have rhinoviruses, we have coronaviruses, RSV, flu, all those things. So coronaviruses have been with humans for a long, long time. This is a different coronavirus. This is a beta coronavirus, and it's called again SARS coronavirus 2. So I said that initially it caused a little bit of confusion because many of the viral respiratory panels that we use for diagnosing respiratory infections includes the regular coronavirus, not this coronavirus 2. So initially some people tested positive for coronavirus, and of course they were concerned that they had this disease, different infection. So we're going to be focusing on SARS coronavirus 2, and for the future, for this talk, whenever I talk about coronavirus, if I mention that, I'm going to be focusing on SARS coronavirus 2, so just to avoid confusion. So this is the virus, and it's called coronavirus because you can see these little spikes that the virus has, that it looks like a crown. That's where the corona name comes from. And these spikes are important because these are the ones that bind to human receptors and cause the infection. So, as you know, it started in China, specifically in Wuhan, one of the largest cities in China, population of about 11 million people. It started there. Probably the evidence suggests that this is a virus that jumped from bats to another animal, pangolins, and then somehow from pangolins jumped into humans. That's what the evidence is supporting at this point. From there, it all started initially spreading areas in China and then to other countries, and we know what has happened since then. So this is the kind of the report of the cases in Wuhan. The first case reported in December, early December, but probably this was floating around in November, of course. The first cases were reported close to this seafood market. There was a response and there was a closure of the market, and then lots of containment interventions, but still, unfortunately, this got out of control. This graph represents the number of cases in Wuhan and how it spiked over really month and a half or so, and then it started plateauing initially and then coming down. And now in Wuhan, at least, there are still seeing cases here and there, but not as much as around that time. But unfortunately, again, this spread to other places, and now it's all over the world. It has been reported in most countries, 188 countries at this point. Over 5 million cases confirmed. Over 330,000 deaths confirmed. This is data as of last Friday when I updated the talk. This is a website that anybody can look at. If you just do a Google search, Hopkins and coronavirus, this is going to be one of the first hits. And you can open that website and it gives you up-to-date information, the number of cases in different countries, the number of deaths. And actually, in addition to looking at the country, if you see at countries in general, if you see up here, you can check on the US, and it gives you specific data for the US with density of cases, also updated cases for per county, and also obviously total number of cases, how many deaths have been reported in different counties. For example, the top 20 counties by number of deaths include Kings County, followed by Queens County, and we know that Chicago and New York have been hit hard with this epidemic. You can zoom the map in and look at specific data for different regions. So this is one tool that you can use if you're interested in knowing what's happening with the outbreak, not only in other countries, but in the US and regional areas. In addition to that, we have another tool, we have a couple of other tools. The Alabama Department of Public Health actually updates data. They use a tool that is similar to the Hopkins one that I just mentioned you. You can again do a Google search, ADPH coronavirus data, and this will come up. And you can see there a couple of things that we have here. One is on the left, we have the number of confirmed cases, number of people tested, cases in the last 14 days. And again, this is as of last Friday. I have not updated it this morning. I was running this morning, so I didn't have an opportunity to do that. And you see that there is a large number of healthcare workers involved, 529 people in the ICU, ventilators, different things. And you can see also the number of deaths so far as of Friday, 536 in the state. When you look to the right, there are different things that you can do, and you can see these little numbers in the bottom. It gives you different screens. So you can look at counties, you can look at total number of cases, you can look at trends, and then you can see where the epidemic seems to be concentrated in terms of, for example, in this case, cases per 100,000 persons. And even though the total number of cases might be higher in some of the counties with the largest cities, in some places actually the outbreak, even though it may not be causing as many cases, the cases per 100,000 seems to be higher. So still a lot happening in Alabama. Another tool, I mentioned Hopkins, I mentioned the ADPH, and there's another tool that has been created called Bama Tracker. And again, you can just Google these, all these are for free. Bama Tracker updates data specifically for Alabama on a daily basis. Here we have the total number of cases, the number of cases, of new cases per day. This is as of last Friday. If you update this data today, you will see a number of cases diagnosed in the last day, how many people have recovered. The R0, which is this is the number that tells you how the outbreak is behaving. To explain a little bit, and you may see this RT or R0 depending on what data you're using. That tells you if you have one person infected, how many additional people are being infected by that index case. So if I have coronavirus and I'm around a number of people, how many of those people got the infection from me? If the number is 3, that means that I'm contagious to 3 people. If the number is less than 1, that means that the outbreak is actually coming down, and that's what we would hope to see, so that less and less people are getting infected. So as of last Friday, this was around 1 because the number of cases was relatively stable, but of course we don't know what's going to happen in the next few weeks. With the BAMA tracker, you can also again look at specific county data. We see here the total number of cases. We see the county that has had the highest number of cases is Mobile, followed by Jefferson and Montgomery. Obviously, you have to correct also for total population, and then even though Jefferson has had a high number of cases, actually in terms of rates, the rates in Mobile and Montgomery are going to be higher, so it just depends on what data you look at. But here again, you can see different counties and the total number of cases there. So 3 tools you can use if you want to know what's going on with the outbreak, and the nice thing about this is that it is constantly being updated on a daily basis. All right, with that background in terms of what's happening in the state at this point, which again, we don't know what's going to happen in the future, it's still early to tell. Important to talk a little bit about transmission. So how is this virus transmitted? As far as we can tell, is what we call droplet, similar to other respiratory viruses, for example, the flu. That means somewhat close exposure. That means being around for some time, not necessarily a few seconds. It's very difficult to tell because some people may transmit more than others. There might be environments where transmission is easier than in other environments. For example, if you're in a closed room and there is not a whole lot of air circulation, maybe a little easier than if you're outside, for example. But anyway, it seems to be droplet, and what that means is that when somebody's coughing or breathing and they are infected, the particles, the viral particles that are around, probably don't travel too far. I'm saying probably because there may be some exceptions, and I'll talk about that in a second. In addition to that, contact seems to be involved, touching areas that are potentially contaminated and then exposing yourself. Surfaces, cleaning is going to be very important, and obviously the hospitals are playing a big role cleaning rooms after the patients are discharged. Now, a lot of controversy about airborne transmission. So the practical implications between airborne transmission and droplet is the kind of precautions you need, if you need negative pressure rooms and if you need N95 masks or not. So far, the evidence suggests that droplet is the predominant mechanism for transmission. However, airborne cannot be totally excluded, and there may be some isolated circumstances where this can happen. Definitely the risk of airborne is higher if you are performing procedures that produce aerosolized particles. For example, if somebody is being intubated, if somebody is receiving CPR, if somebody is receiving nebulization treatments, anything that can just spread these particles may increase the risk of airborne transmission, and in those situations, definitely N95 masks are suggested. On the other hand, for routine care, probably droplet is okay. But again, there is still a lot of discussion about this, a lot of controversy, and people talk about 6 feet because that's what has been studied for other respiratory viruses, but there are some studies showing that maybe 10, 12 feet away you may find some viral particles. Still, when you look at what has happening, for example, in controlled environments like hospitals, when hospitals have implemented droplet precautions with other precautions like the mask and gowns for contact, transmissions seem to be actually quite unlikely to happen. On the other hand, when those things were not happening and people were still perhaps being exposed more early in the outbreak, there was a lot of healthcare transmission. So to summarize, probably droplet is the main one, some contact, airborne, not impossible, but unlikely. There has also been concern about transmission in the community from fecal contamination because the virus can be found in feces, but there is no evidence to say that that's playing a role at this point, like with, for example, polio viruses. So primarily droplet, maybe aerosolized. What is important to do? What are the important interventions to follow to prevent transmission? Hand washing. So we're talking about contact in addition to droplets. So washing your hands using hand sanitizer, the 20-second kind of thing, extremely important, doing all the time, because we never know when we're going to touch something that could be contaminated and then expose ourselves. Cleaning the rooms is going to be extremely important, and our employees who help with that play a major role. Keeping distance, the social distancing that people talk about, here it talks about 2 feet, which equals 2 meters, which equals 6 feet. Again, because most of the transmission seems to be droplets, so those particles hopefully will drop before they reach the next person. What we know is that most people develop symptoms within 4, 5, 6 days from exposure. Some take up to 2 weeks, but most people within 3, 4, usually 4, 5, 6 days is when they start developing symptoms. Personal protection equipment, lots of guidelines from different institutions, different organizations, from World Health Organization to CDC to local health departments to your own hospital. So bottom line, your hospital knows what they are doing. They follow national and state recommendations, follow their institution guidelines, because in addition to having a little bit of controversy in terms of the guidelines of what works and what doesn't, we also have to keep in mind that there are problems with access to this equipment. From the beginning, it's been hard to find masks. N95 masks have been difficult to obtain, even gowns. So in many places, for example at UAB, what we're doing now is the N95 masks are being cleaned up, sterilized, and then used again, because we cannot continue to just buy N95 again. There is just not enough supply. So just follow the recommendations that your hospital is providing. But if we just look at one of those guidelines to kind of give a little bit of support of the statement I made before, this is the Infectious Disease Society of America guideline for personal protection equipment. So, in the setting of people who have COVID-19 or who are suspected to have COVID-19, for routine care, you could use either surgical masks like this one, or you could use N95. The evidence does not really strongly support the use of N95 in absolutely everything, in every situation where we're around somebody with COVID. In addition to that, of course, if we know the patient has COVID or is a person under investigation, a PUI, we need a face mask, we need the gown, we need to do the donning and doffing, all those things. Don't get me wrong, it's not just the surgical mask. But if you are in the same situation, but a person is having some kind of aerosol generating procedure, such as intubation, CPR, nebulization, suctioning, endoscopies, then you should really use an N95, because then the transmission dynamics may change. But initially, we thought that N95s were needed for everybody. Now we know that surgical masks appear to do okay, unless we're generating those aerosol particles. So some data to look at some of these aerosol generating procedures: tracheal intubation, manipulation of oxygen mask, tracheotomy, manipulation of BiPAP. You can see the data here, but that includes bronchoscopy, includes insertion of NG tube, includes CPR, defibrillation, collection of sputum samples, so we have to be a little careful with that. Whenever we're participating in any of these procedures, we should really wear the N95 and not just the surgical mask, and we should still continue to wear the face shield and the gowns and do the donning and doffing, and I'm sure you have been trained on that. Now, this is the overall general information. However, something that we learned with, we have known for a while with TB, and we learned also in the SARS outbreak. And there seem to be some people who are what we call super spreaders. So even though I'm telling you that in most circumstances, transmission seems to happen with close contact for more than 10 minutes, within 6 feet, no protection equipment, there are some situations when actually people, for some reason, maybe they are coughing a lot, maybe they are singing, maybe they, for some reason these particles are just spread out more than just these 6 feet. So it's not a rule that is always really accurate. Sometimes the particles may travel more. So for example, there are a couple of MMWR reports in the last few weeks. One was in a practice where people were singing intensively, and actually part of this was that they were very close together. One person developed symptoms around the time when the singing practice happened, and of these people in the group, one was enough to infect 87% of people around them. But again, this was not just casual contact, this was an intense singing practice with people close together. There was a recent event also involving a church where 2 symptomatic people attended church events on 3 different days, and then 35 of the 92 people who attended church got COVID. And unfortunately, even one of them died. Of the previous group, the core practice, actually 2 people ended up dying. So we still have to be careful as the restrictions to move around and practice and social distancing kind of disappear. This is not going anywhere. This is still around, and we still have to be careful. So keep in mind these things as you talk to patients and educate them about how this is transmitted. All right, with that background in terms of how it's transmitted and where it is and potential super spreaders, let's talk a little bit about clinical manifestations. We don't know how many people are asymptomatic. Some studies have reported 1%, some studies have reported 50%. And the problem is that, as you can imagine, we don't necessarily have a gold standard. People who are getting tested are the ones who have symptoms. They are starting to do some studies in populations where investigators, physicians, healthcare workers know that there has been an outbreak, and they are just starting to test everybody retrospectively to see who has evidence of recent infection. It may be that as many as half of the people who are exposed and get infected develop symptoms or not develop symptoms, or it may be that most people develop symptoms. Of those who develop symptoms, about 4 in 5 or 80% have symptoms that are mild to moderate. Some of them, I've had some patients who had a little bit of a scratchy throat, low-grade fever one day, and that was it. I have had people who were miserable at home for 1 week or 10 days before things got better. But when we're talking about mild to moderate, what we mean is that they do not require hospital admission. They may still be miserable at home with symptoms, but they didn't require hospital admission, mostly for respiratory compromise, of course. Of the 20% who require admission, about 15 of those 20 just require a hospital stay, some oxygen support, they get better. But about 5% get sick enough to require intensive care unit care. Symptoms, common symptoms, fever, cough, which can be dry but also can be productive. Fatigue is quite common. Body aches is quite common. Other things that you may see, upper respiratory infection symptoms like runny nose, sore throat, they are not as common as with other respiratory infections, but they can happen. Headache is quite prominent. Some people have GI symptoms like nausea, vomiting, diarrhea, although they are not necessarily that prominent, but again, people present in different ways. One interesting symptom with COVID-19 has been the loss of the senses of smell and taste. People will tell you that they have a little bit of a low-grade fever, maybe some body aches, and they just can't taste something. There are reports of patients telling, their wives, hey, why did you cook this like that today? I mean, it's totally different than what you usually do, stuff like that. Or also not being able to smell coffee, for example. And that seems to be a not uncommon symptom for COVID-19. Initially was not recognized until a lot of people started describing that. So again, fever, cough, sometimes shortness of breath, fatigue, myalgias, headache, those are going to be the most prominent symptoms. Unique symptom perhaps is this loss of sense of the smell and taste, but other, a little bit of a red eye, some runny nose, some sore throat, some diarrhea, some vomiting can happen as well. Most of the symptoms evolve over time. So these are not usually patients who get really sick on day one. I mean, if you remember the patients that you may have seen with flu, sometimes they can tell you, I was perfectly fine this morning at 11 a.m. I had terrible headache and body aches and chills, and now I'm miserable. These are patients who just kind of gradually get better, and usually they don't get really sick if they are going to get sick and require ICU until later in the course of the disease. So it may take days before they see that. Other weird atypical symptoms that are being reported. So some people have started talking about COVID toes. You can see pictures here where some people develop skin lesions. Sometimes this is the predominant symptom, sometimes it's part of additional symptoms that we saw in the previous slide, but some purple blisters or purple lesions in the toes, some livedo-like with kind of like a net kind of appearance in the feet, that has been reported. Strokes, There is a question about hypercoagulability, increased risk for clots in COVID, and some of that obviously can show in the lungs, but sometimes in other places. So there are several reports of people getting strokes in the setting of COVID, encephalopathy with confusion. I already mentioned eye symptoms. Not typically a presenting symptom, but maybe part of the whole picture. And then more recently, in the last couple of weeks, initially from New York, and then we have heard about it from other places as well, this thing that has been defined as multisystem inflammatory syndrome in children, kids or younger than 18, who develop something that looks like Kawasaki syndrome with fever, rashes, a lot of inflammatory symptoms, sometimes lymphadenopathy, sometimes again rashes or mucosal lesions, sometimes with evidence of active coronavirus infection, COVID-19, sometimes with evidence of previous infection. And they are right now studying this group of patients. So initially, you know, I'll talk about age in a second, but clinical manifestations in kids were pretty mild in the initial reports, but now we're seeing that even kids can get sick. Severe disease. Clearly tenfold higher than seasonal flu. So the concept that this is just another flu is totally wrong. The mortality of COVID is clearly tenfold higher than, based on the data we have, than seasonal flu. Seems to be a little bit higher in males than females. We don't necessarily know why. There are lots of theories, but we don't know why. Definitely the mortality correlates with who you are. Age, comorbidities play a very important role. In those who are relatively young and otherwise healthy, the case fatality ratio, CFR stands for that, is low, less than 1%. When you're adding cardiovascular disease, it goes up to 10%. If you have diabetes, 7%. If you have something like COPD, 6%. Hypertension, 6%. Cancer, 5.6%. And of course, living in the Southeast, many of our patients will have these comorbidities. So we're seeing a lot of this in our patients. Data from the right is from Italy. As you know, Italy was hit hard before the US, and lots of deaths over there, lots of problems, in particular in northern Italy. And you can see here that the mortality in people who had ischemic heart disease or other comorbidities in the cardiovascular area was quite high. In those who had no comorbidities, the mortality was low. In those who had 3 or more, you're talking about even like almost like a 50% mortality. Age, definitely much lower risk in young people, although not impossible for, there have definitely been young people who have died, including healthcare workers and children, but definitely lower. And when you're reaching 70, 80 years of age, then you're talking about a much higher mortality, 15%. So definitely a correlation between age and risk for severe disease. And this is obviously important in terms of the epidemiological complications and implications, because a lot of the people who might be exposed when we're kind of coming down in terms of the restrictions of movement and exposure may not necessarily get that sick. They may be okay, but they may be around older patients in stores, in the family, in the house, visit relatives in hospitals and other places, and if they get it, they can have a quite high mortality, so that's something to keep in mind. So the case fatality ratio in the US is different than in Italy. Not clear why, definitely higher in Italy, but some of that may have to do with access to healthcare. They definitely have a very good health system, but not necessarily too many ventilators, for example. So in the US so far, the case fatality ratio has been somewhere between 1.8 and 3.4%, definitely lower in younger than 54, but up to 4% of those patients ended up in the ICU, and some of them died. Increases again with age and comorbidities, we already talked about this. So what does severe disease mean? First of all, it means respiratory. So these patients develop respiratory failure, a picture of ARDS, requiring intubation, ventilatory support, many times for weeks. These are not necessarily patients who get intubated today and 2 days later can get extubated and go home. Once they are intubated, most of them end up, if they tolerate that, most of them end up staying on the vent for a long time. Acute kidney injury has been very common, many patients requiring dialysis, cardiac injury, even with myocarditis, and need for support ECMO even. So what are some of the markers of severe disease? The patients who develop severe disease or who already have severe disease, in addition to the clinical manifestations of significant hypoxemia, pulmonary infiltrates, cardiac injury, renal failure, hypotension, other things, hepatitis as well, many times you will see troponin that is high. Inflammatory mediators and markers such as interleukin-6, D-dimer, ferritin, C-reactive protein go very high, LDH goes high, and another marker, or perhaps a prognostic marker for severe disease, is lymphopenia. Lymphopenia, low lymphocyte count, is common in COVID and also tends to correlate with more severe disease. So going back to the comment I made before in terms of how long it takes for people to get really sick. So in general, you have the exposure, and one thing to keep in mind that I forgot to mention before, asymptomatic people who have no symptoms if they are infected, can still transmit the disease before they get symptoms for about 2 days. And actually, when you look at the viral dynamics, how much virus concentration people with the disease have, many times actually they have the highest concentration of virus early in the disease. So even when they are not having symptoms, they can have a lot of virus around and they can certainly transmit it, which is part of the problem that we're seeing, and how one of the reasons why so many people have gotten infected in the world so far. So we have the incubation period, we start seeing viral replication, and you may or may not have symptoms here, but you still can transmit. Then you develop the symptomatic infections, which people talk about the viral kind of phase, where you have a lot of viral replication, you have the fever, you have the body aches, the myalgias, all the different things that we talked about, the headaches, but they are not that sick. After a little while, you start seeing more of the complicated picture. That's when the oxygen level drops, when you start developing multi-organ failure, and people have correlated that with what they call the host immune response. So you may not have that much virus anymore, but actually the amount of inflammatory response that the body has is going up. And there is a lot of concern that that's actually what's triggering a lot of the severe manifestations. That you may have heard of cytokine storm. So this is when the interleukin-6, interleukin-1, other inflammatory markers go sky high, and that may be causing overreaction to the viral infection and organ damage from that perspective. Perhaps also that explains some of the increased risk for coagulation that we're seeing in some of these patients. So the severe symptoms usually happen 7, 8, 9, 10 days after the onset of symptoms. So the fact that somebody's doing okay the first 3, 4, 5 days doesn't necessarily mean that bad news are not going to happen next week. This is the time when people really get sick, and most of the people who end up getting admitted to the hospital have been sick for a number of days. And then you have the resolution. This may or may not have implications for treatment, because the theory is that the first phase of the disease is more of the virus replicating and causing some response. The second phase of the disease may be more of the reaction to that virus. So people are proposing that perhaps the way to treat this virus will depend on when you are. If you are here in the viral response, you need to focus more on antiviral agents. If you are here on the cytokine storm host immune response phase, you may need to work more on controlling the inflammatory response, or a combination of both. Truth is that we don't know. Studies are being done to try to come up with better answers of how to treat these patients, but right now we don't really know. Okay, so deaths. So something that has been seen in the US, not only here, but was very prominent in New York, in New Orleans, in Chicago, is minorities being affected out of proportion to demographics. What I mean by that is the mortality that we're seeing in Alabama as well, and again, this has been reported from New Orleans and other places, minorities are being affected much more. Hard to tell for that, but why, but probably related as usual to access to care and presence of comorbidities, hypertension, cardiovascular disease, obesity, diabetes. So this is data for Alabama, and as you can see, in terms of the deaths, 43% of the deaths have been African Americans. Moving from manifestations, severe disease, to radiology, and then we'll talk a little bit about diagnosis. So on radiology, depending on where not where. When you are seeing the patient, you may see different changes. And many times things evolve over time, as you can imagine. The classic description for this disease is ground glass opacities, like you can see in this case, kind of haziness where you can still see a little bit of structure of the lung underneath, but bilateral opacities, sometimes upper lobes, it can be unilateral, it can be bilateral, but these things over time progress to a more dense or consolidated kind of picture. But now, many times the radiologists are telling us, consider COVID just based on the fact that the patient has bilateral ground glass opacities. Another example of ground glass opacities, but in this case you see how it has progressed to all the lung with some consolidation as well. But this is the same patient, and you can see how infiltrates can change. On the right, I'm talking about. So this is day 3, this is day 7. They can see my pointer, correct? Excuse me, sir. Okay. So day 11, day 18, and you can see how the infiltrates change over time in the same patient. Testing. Okay. Moving target. Really, what I mean by that is initially, testing was extremely difficult. I'm sure you experienced that here. At UAB, when we had our first round of cases, it took a while to get answers. The health department was overwhelmed with tests, and they didn't have the resources to run all of them. Finally, there were lots of efforts to get testing available, so now it's actually much easier to get testing compared to late March, as you know. But still there are some difficulties accessing the test, and you know that. In my institution, for example, the rapid test, the one that gives you an answer within 2 hours, we only have a few of those, and they have to come up with guidelines of who gets that test versus other people. But testing in general for the US, we're talking about PCRs. We're talking about molecular testing that detects genes of the virus. So initially when we started testing, really was based on symptoms and epi. In the beginning was only somebody who had a history of traveling to Europe or China or something like that. Now obviously that's not what we need because the disease is there. So based on symptoms, following state and local agencies, and these guidelines have changed over time many times depending on availability of testing and also what's happening in terms of epidemiology locally. At UAB at this point we're testing everybody. So anyone who gets admitted to the hospital gets a test. And we have been surprised many times. People who we did not suspect COVID ended up testing positive. Most of them actually, of the ones who we did not suspect, had difficult to obtain history. So people with encephalopathy, people who came from nursing homes, couldn't really tell us much. But there was no obvious respiratory symptom or hypoxemia. They got tested and they got a positive test. So testing at this point mostly is in nasopharyngeal samples, so the swab going into the back of the nasopharynx. And then other tests, if you're going to be collecting saliva or sputum, really needs to be locally validated. But the nasopharyngeal test is the one that is kind of universally available. At UAB, for example, we have the lab has validated BAL now, so we can test BAL, we can test CSF. But in most places, we're talking about nasopharyngeal sample. It's not perfect. We have had patients who we strongly suspected COVID. First test was negative, repeated one, and the second one was positive. Also, there are reports in the literature of people who had negative 2 or 3 tests, nasopharynx, and then when they got a BAL, for example, or a deep sample, and if they were intubated, the test was positive. So I don't know if this will work or not. Let me see. This is a video, I don't think it works. I would encourage you, if you have a phone, just take a screenshot of this website. It's not running from here, but take a shot of this website and then go online. It's for free. It's a New England Journal of Medicine video that shows you step by step how to collect the sample. Now it goes from like the donning and cleaning hands and everything. If you already know how to do that, you can skip that, but then focus on how the sample is collected, because the important thing is that the optimal nasopharyngeal sampling is not fun. It should be difficult to obtain. This is not swabbing the tip of the nose. When you see the picture here, you see it goes all the way to the back of the nasopharynx. So really you should go in about this long, touch, hit the back of the nasopharynx and sample there. That's not easy to do. And many adults will not let you do that or will not necessarily cooperate. In kids, it's a little easier because you grab their heads and you just push and pull. But in adults, maybe difficult. So just keep in mind that when we talk about sampling and perhaps getting false negatives, we have to keep in mind that we are not always getting the appropriate sample. So again, I would encourage you to go to that video, that link that I put in there so that you can watch the video. But really, you should go all the way in, kind of roll it a little bit, leave it there for a few seconds, and then pull it out. And that gives you a good sample. Serologies, so blood tests for COVID, not routinely recommended by the CDC. They are being used all over the world, and it has created a lot of confusion because some of these tests are actually not good. The problem is, I already told you that there is a lot of coronavirus around. We're talking about SARS coronavirus 2 here, but most of us, or many of us, have been infected by other coronaviruses causing just common cold that we didn't even know in the past. So there may be some cross-reactivity where we check serologies or antibodies against these coronaviruses, and it may show up positive just because we saw some other coronavirus 20 years ago or whatever. So labs, commercial labs, and also the CDC are developing more precise and specific antibody tests. But the problem is that lots of the tests that have been released have not necessarily been tested appropriately. So there are tests that appear to be better than others. I don't know what tests or if you're using any of those here. But in general, there are actually websites that give you the specific characteristics for each of these tests. I would encourage you, if you're using a test, to make sure that you know which one you're using and you know what the specificity and sensitivity are. This is so potentially difficult to interpret that the CDC is even saying that if you're going to get serology to see if somebody was infected before, if the test is not that great, you may even want to consider 2 separate tests before you really tell somebody that they have been infected before. Because some of the things that people are talking about is, for example, if a healthcare worker had some runny nose and didn't say much about it in February or in March or April, and now, well, maybe I had it, so is it safe for me to go back to work, those kinds of things. So people are starting to think about running this test to see if there is evidence for previous immunity. There are 2 problems with that. One is, again, I told you that the test is not perfect, so it's difficult to totally trust that result. The second one is that so far, we do not know for sure if reinfections are possible. They seem to not be happening. It seems to be okay, so somebody who has developed this infection and got cured, probably protected, but I'm saying probably, we don't know for sure. When people are looking at this, we will need time to know for sure. When you look at the antibody response, some patients develop antibodies that when tested in the lab work great. Some others develop antibodies that are not doing anything to the virus later, so we just don't know. So it's more to come in the next few months as we learn more about the disease. But so far, in terms of like the reports of people who have had it before catching it again, it doesn't seem to be the case. I know you may have seen in the news people who got sick again or had a test done again. The PCR, by the way, that I mentioned in the prior slides, can stay positive for a long time. And that doesn't necessarily mean they transmit. It seems like after 10 days or so, even if the PCR is positive, transmission is not necessarily happening. So the PCR is also a little tricky in terms of testing it again and again to prove that the patient is not transmitting anymore. It looks like after 10 days, even if PCR detects the virus, it's probably dead virus that is not being transmitted, but it's still being picked up by the test. So this is what I was talking about, that the CDC is still a little iffy about the serologies. If you use one, pick one that has excellent specificity, and that's a wonderful test. To have a test that has specificity of 99.5%, that's a very high standard to reach. So most tests actually will not reach this level. But you can look it up and see if the test that you're using, if you're using a test, meets this criteria. Or use 2 separate tests, and if both are positive, then okay, that makes sense. Treatment, big question mark, because we don't know how to treat this disease. We know supportive treatment helps, but the specific treatment, we still don't know, and I'll talk a little bit about this. So I mentioned kind of like how the virus binds with the human receptors and then causes the damage. So really, this is a complicated slide, and we don't need to spend time on this, but this goes back to the comment I made before. There are 2 separate kind of potential targets here. So we have the virus component of the treatment, giving a treatment to kill the virus. That may theoretically help more early in the disease because, as you saw in the previous slide, that's where the virus is actively replicating. But then we have the inflammatory response that the body mounts against the virus. So the virus may be on its way down, but then we have the inflammatory response that seems to be causing some of the symptoms. So some of the treatments may be directed to blocking that inflammatory response. So we have one side of potential agents that blocks the virus or kills the virus, and we have another side of potential agents that hopefully will block the inflammatory response against the virus. Supportive treatment is still key. Oxygen, symptomatic treatment, monitoring for complications, those kinds of things. In terms of agents that seem to have activity against the virus, you have heard a lot about hydroxychloroquine, chloroquine plus minus azithromycin. The initial case series suggested some benefit. More and more studies now have come out saying that it doesn't seem to work. And actually the most recent studies even show harm. Higher rate of mortality in one study, higher rates of cardiac arrhythmias in other studies. So some of the enthusiasm for these agents that happened initially is going away. There are still randomized clinical trials running in some places, but a lot of the cumulative data that we have had in the last 2 months really suggests that we should not use this. WHO over the weekend actually stopped one of the arms of a trial they are doing that included hydroxychloroquine because, again, they are seeing some potential harm. So I think even though some of us may have thought about it initially, I think the data suggests that we shouldn't be doing it. Remdesivir is an antiviral agent. There was a study that was announced about 2-3 weeks ago and published last week. UAB was one of the sites. And the outcomes were that people seem to recover 4 days earlier. So actually FDA has provided an emergency use authorization, and now access to this is very limited. It's distributed by the government. So Gilead, the company that produces it, has given control to the government to distribute this, and they have sent doses all over the country. Limited number of doses. So at UAB, for example, we have some criteria when to use it. I'll show you that in a second. Other agents that have been tried, boosted protease inhibitors that have been used for HIV, lopinavir, ritonavir, they seem to have a little bit of in vitro activity against it, but the only randomized control trial that was done showed no benefit, so we're not routinely using it. Interferon, ribavirin has been used, and the other thing we're using at UAB, but again, no real data for those, I should say. The other thing that we're using at UAB is convalescent plasma. So plasma from individuals who have recovered from COVID, again, have hopefully mounted some immune response with antibodies to kill the virus, and giving that plasma to those patients. We don't know if it works or not. There are some preliminary case reports suggesting that it may work, but we don't really know. And the other thing we don't know is when to give it. Because again, is this going to be something that as an antiviral agent only works early in the disease? And when the patients come in the later phase with inflammatory response, you're not really providing benefit because now actually you have a very profound inflammatory response with not that much virus? We just don't know. So at UAB, these are the criteria that we use for remdesivir use. We also have a clinical trial running that includes remdesivir with an anti-inflammatory agent I'll talk about in a second. But different institutions are using different criteria, and local guidelines will apply. When we focus on the other part of therapy, the anti-inflammatory, steroids have been proposed, but it's very controversial. Steroids have been used in SARS and MERS, the other severe coronavirus that I mentioned before, and actually they showed no benefit, and in fact they showed prolonged viral replication. So people continue to have virus for longer when steroids were used. So at this point, steroids are not really recommended routinely, at least in the US. In some places they are giving them. Perhaps they can be considered in people who have ARDS. So sometimes they are doing that in the setting of respiratory failure with ARDS, but again, we do not know when they work. Agents that modulate the immune response, IL-6 blocker, tocilizumab, you may have heard about that one. Baricitinib is a JAK inhibitor, also blocks inflammatory cascade, and also seems to have a little bit of antiviral activity. So that study that I told you that we're running at UAB, remdesivir plus minus baricitinib is what we're doing right now. And again, just to see if we can treat both the viral component and inflammatory component. So it's a multicentric study. We'll see what that shows. Obviously, we don't have results yet. Anakinra is an IL-1 blocker that is also being studied. And there's a long list of studies. If you look at clinicaltrials.gov, running studies for COVID, there are hundreds of studies right now. So I'm just putting a couple of examples there. There has been mention in autopsy studies about clots being very common in these patients. So some people have proposed using anticoagulation. We do not know. Definitely consider prophylactic anticoagulation, but to jump from there to give full-blown anticoagulation to everybody, in some places in Europe and in South America they are doing that. In the US that's not the standard of care, but something to consider, or at least have in the back of your mind that these patients tend to have clots and you may need to look for those. We may have some monoclonal antibodies that block the virus at some point, hopefully, but we just don't have that yet. So this is the treatment protocol that we use at UAB. And as you can see, really we're talking about mostly support therapy. So symptomatic treatment, oxygen supplementation, DVT prophylaxis. But then for the sick patients, consider remdesivir if you have access to that, but also consider including them in clinical trials. And really what we try to do is place the patients on these clinical trials so we can get answers of what really works. Because right now, other than remdesivir showing perhaps some advantage, and by the way, to expand on that, initially it was just released that the outcomes were better, but now that we have the paper, the benefit seems to be more in those who are not that sick, actually. You may think that actually we should focus treating the ones who are the sickest, but it looks like those who are the sickest probably don't benefit from the remdesivir anymore, and you may need to focus more the treatment on the ones who have not reached that point yet, but again, we don't know for sure. You may have heard about ACE inhibitors and NSAIDs. So the issue here is that I showed you that spike protein of the virus in one of the first slides. That actually binds to human receptors. The human receptor is the ACE2 receptor, which is present in lungs and in other organs. So there has been concern that if somebody's taking an ACE inhibitor, perhaps the number of receptors is going up, and maybe you will have more places for the virus to bind, and you will develop more severe disease. All is theoretical. We do not know. Many organizations, including American College of Cardiology, WHO, and some others, have said, ignore this for now. If the patient is on ACE inhibitor and needs the ACE inhibitor for comorbid conditions, keep going with that. So don't stop ACE inhibitors or ARB just based on this concern, based on the information we have at this point. All right, so another question that is quite common is if you have a healthcare worker, when can you go back to work? So these are the CDC guidelines, understanding that your local institution or your hospital may have guidelines that are used by this institution, but this is what CDC guidelines say overall. Okay to go back to work if no fever and improvement of symptoms and test negative ×2 at least 24 hours apart. One caveat with that is, as I mentioned before, the PCR may stay positive, so that may create a little bit of a confusing situation there. Or if you're not doing the 2 tests, no fever or at least 72 hours and improvement of symptoms, and it's been 7 days since starting to feeling sick. Some people are using actually 10 days. And then the other thing is, even if you go back to after the 10 days, that, I'm saying 7, but it's really more like 10 lately. Even if you go back to work, probably still a good idea to be very cautious about who you're around and avoid direct contact with immunocompromised patients for about 14 days until the symptom onset. In those who were tested because there was an exposure but they never had any symptoms, if that individual has had no symptoms for 7 days, it's safe to go back to work. And again, these are guidelines for healthcare workers based on CDC. The problem is, again, I mentioned 7 days, sometimes they talk about 10 days. But the other thing to make it more confusing, I guess, is that some local agencies may have specific guidelines. For example, ADPH still uses 2 weeks. So if you're a healthcare worker who gets diagnosed, you may get CDC guidelines saying maybe 10 days, your hospital saying maybe 7-10 days, but then Alabama Department of Public Health may say still 2 weeks. So unfortunately, these guidelines are fluent. Just contact your employee health office and they will use whatever is pertinent for your particular institution. Okay, so for, this is for people who, this is just directly from the CDC, for people who are not healthcare workers, you have to keep in mind a little bit of what they do. But again, in Alabama, what the ADPH is suggesting is a quarantine for 14 days. So if the test is reported to the health department, they contact the patient and they ask them to quarantine themselves for 14 days before going back out. And obviously be aware of who's at home, probably use a separate bathroom, separate room, try to keep as much distance with the rest of the family so that the rest of the family does not get infected. And actually that brings me back to an interesting point. In places where they're having outbreaks, a lot of the transmission has been in-house transmission. Definitely transmission in the community, but a lot of that disease is being brought to home, and then at home, a lot of transmission with relatives, sometimes spouses or kids or other people. All right, so that's what I have. Again, we are not going to have the opportunity to do live questions, but if you have any questions, please feel free to send them my way. You can send them through the people responsible for the talk. But in addition to that, my email is as in Martin, Rodriguez, RODRIGUEZ @UABMC, medicalcenter.edu, and I can try to answer your questions. Feel free to email me if you have any. So thank you very much, and I appreciate your attention.